So today, everybody, we're going to be doing a little something with the Minnesota Department of Health Task Force on Pregnancy Health and Substance Use Disorders. I have with me Samantha Grant, who's the Senior Management Consultant in Management Analysis and Development. Like, I know what that means. I don't. But it sounds really, really important. And then we have Brittany Wright, who is Program Director of the Governor's Children's Cabinet, and she is the kind of the co-chair with myself on this committee. And this committee is all about changing what the requirements for reporting and for reporting and what's the word I'm looking for, Samantha? Reporting and testing for
Testing.
testing for patients while they are pregnant, because as we all know, it's a pretty complicated system. And if you've delivered babies or taken care of babies in this state, sometimes knowing what to do is complicated. And so there are some changes coming. We're going to talk about that today. Really what this is about today is also getting input from all of you, thoughts that you might have about some of the things that we have slowly developed over the last 6 months. So for us, it's this is a chance to throw some of these things out here and get feedback. Next slide, Katie. So some of the announcements, remember, there's been a SOAR echo change. We were weekly for 6.5 years. We just cut back to every other week. And so having just a little bit less stress on my side, to be honest with you. We have some really good talks coming up. And actually, in 2 weeks from now, myself, Dr. Alex Hubble, an addiction doctor in the Twin Cities, and David Rossmiller, who's on today, are going to be doing some buprenorphine rounds, some kind of case reviews to try and help people kind of navigate. Here's a patient that shows up in this particular situation. How do I dose their buprenorphine and how do I get them into recovery the quickest? We have some zero suicide talks coming up. Charlie Resnikoff coming back in October. He has some interesting talks on optimizing buprenorphine as well. We have some other things that are coming that aren't on the list yet, clear out to October and November. So lots of fun talks. Next slide. Remember, there's free CME. Somebody's saying my volume is a little low. Is anybody else experiencing that as well? No, nobody else is. So, Tiffany says it. Let me put the headphones back on. I'll finish this first. Remember, there's free CME. We would love it if you'd turn on your video. For myself and Brittany and Sam, it's sure nice if we can see faces and not black boxes. Always makes it a lot more fun. Remember that when Katie sends you the things, it's just important you send back if you want the free CME. Next slide. Remember, technical assistance, if there's anything that you need from us, please give us a call. We have our cell phone numbers there. I get a lot of calls about patients all over Minnesota. It's fun to get them. They're always interesting. Any way we can help you with patients kind of in crisis, we're happy to help. So reach out if you need to. And remember, you can go online. All of our resources are online for the last 5, 6, 7 years. All the different things that have done. There's recordings of all of the echoes that you can go back and watch. So just understand that all of that stuff is right at your fingertips. Next slide. And that is it. So we will let Samantha or Sam, we will let her kind of start out. She's going to kind of do the introduction for us and kind of talk a little bit about how this whole task force and everything really got going. So go ahead, Sam. And if those your slides that you're now?
Yes, I am sharing. So hopefully you're able to see the slides and hear me well. Yes. Can I get a nod from Brittany and Kurt? Good.
Yeah, I can hear you well. Can you hear me better now?
You sound the same to me, but I have a headset on and you sound fine.
Okay, perfect.
So bump up the volume when Kurt is talking and turn it down because I'm a former theater major. So I project maybe too much when I'm speaking. So thanks for joining us today. Like Kurt said, I'm a senior management consultant, which basically means I work with a bunch of different people in state government on a variety of different projects. And the one that I'm going to be talking with you today is a task force that was created on pregnancy health and substance use disorders. I work alongside my colleague Stephanie Heim, and we are not content experts, but you're going to be hearing from some of the experts on the task force. So we affectionately wrangle this group to share their great feedback and to help to create a report at the end to share with the Minnesota State Legislature to recommend some protocols. So thanks for listening in. I want to just cue you ahead of time. We're going to be stopping to ask you for some feedback. We'll also have a form that I can share at the end of our presentation for you to give more focused feedback. So if you see anything in the recommendations that we're sharing, please take note. We want to hear from you. This is part of our public input process. So
it's important to people, if you want to, please put it in the chat, or if you want to unmute, don't be afraid to interrupt us.
yeah. And we'll be having some stop breaks where you can make sure that you share some of that good feedback. So the task force was established through legislation. There's a state statute that said that there is to be a task force on pregnancy health and substance use disorders. And the purpose of this group is to recommend protocols for when physicians, advanced practice registered nurses, and physician assistants should administer a toxicology test and requirements for providing notice or reporting for prenatal exposure to a controlled substance. So the legislature said, we need to know more about what's happening in this area. We need to get some experts together as part of a task force to give us some recommendations to move forward with. So those of us who are talking today, I'm helping to facilitate, and Kurt and Brittany are co-chairing this task force. We have been meeting since December of last year. We have 7 meetings that happen throughout a 14-month period. In our first months, we thought it was really important that we create a shared foundation. We made sure that task force members got to know each other and got to know their expertise areas. We dug into and defined the problems related to testing and reporting. And I would suspect from where you all are sitting in your work roles, you know a lot of these problems, but we wanted to have those conversations together. And then we needed to build a better understanding of existing laws and also the research around testing and reporting. And there is a lot of research and a lot of wisdom around better testing and reporting protocols. Throughout the spring and summer, we've been identifying best practices, and we've also been learning from other states who have implemented similar protocols. We've looked specifically and met with people from Connecticut and from Colorado, as well as a few other states throughout the United States to learn about what they're doing and how they have reformed some of their policies. We've started working in work groups, and we in June had initial protocols that we discussed as a task force. And now we are we've started to develop and refine our protocols. And so what you're hearing today is iteration 3 or 4 of our testing and reporting protocols. And these are the ones that we know that we have some work to do on, but we want to get feedback from community members, from medical providers, from people who are working with those with substance use disorder. And from your recommendations, we're going to refine our protocols. And in legislation, we've been tasked with, by no later than December 1st, submitting a written report on the task force's protocols for testing and reporting. So you're going to hear a little bit more about them. Brittany can drop this link in the chat because I don't think from Zoom you're able to highlight the hyperlink, but we have 20 members on our task force and they come from a variety of professional and lived experience backgrounds. You can see who they are and where they were appointed from on our task force website. And there's also some other information on the task force if you're curious about who we are and what we've been working on as a team. Our meetings are also available for you to listen on YouTube Live. So if on the website, you'll see our meeting schedule. So if this cues some more interest from all of you, we welcome you to join the YouTube live stream during our next meeting, which will be happening in September. Just a couple more grounding principles. When we first came together as a task force, one of our first deliverables was that myself and Stephanie conducted interviews with all of the task force members. And from that, we learned a lot about shared problems that we see, shared solutions that we hope to create together. Today, I'm going to share the hopeful things that we learned from our interviews together. And these were the shared values that we wanted to bring into any recommendations that we put forward. So I hope that you're seeing these values live out in the recommendations that Kurt and Brittany will be sharing shortly. And one shared value is that we are people-centered. We believe that people and patients need to be part of their care, and we need to treat people as human beings, believe in them, and allow them to be experts in their own lives. We believe in self-determination and that people have their own agency, and we have to meet people where they are at. We have the shared value that we need to be trauma informed. We recognize that there are intergenerational impacts of historical and cultural trauma, including adverse childhood events. And then, especially on this topic, we think it's highly important that we're family-based. We know from research and from practice that substance use is not one person's disease or struggle. It affects everyone in the family. In our protocol specifically, we care very deeply about the pregnant people, their infants, and their family units. We know that there is a lot of trauma with family separation, especially after birth. And so whole family solutions are important to the ways that we create a system of support. Our shared hopes as a task force is that we want at the end to have better care and better substance use and environmental supports for those with substance use disorder. There is deep research that shows that good prenatal care is important for the pregnant person and also for the infant. So we want to continue to have strong care. We also know that there is stigma and fear around this issue, and we need to unpack that. And we hope that we can reduce stigma for pregnant people who are experiencing substance use disorder. And then we also know that there is bias in the system. And so we want to develop equitable and ethical testing and reporting protocols. So we're hopeful that as we go through today, you're going to see these shared hopes and these shared values in the recommendations that we're sharing with all of you today. So with that, I'm going to first make it clear these are draft. We didn't make draft on every slide, but these are drafts. The reason that we're here today is we want to make them stronger. We want to get input on them, but they are drafts. So don't share them with others as if they are set in stone, because we know that they're going to change and evolve and get even better. So with that, I'm going to turn it over to Brittany.
Thank you, Sam, and good afternoon, everyone. Again, my name is Brittany Wright. I'm a program manager in the Governor's Children's Cabinet and one of the co-chairs on the Task Force for Pregnancy, Health, and Substance Use Disorder. I'm going to read the first couple of recommendations, and then we'll take a moment to kind of pause, reflect, and hear feedback from all of you. And of course, as Kurt mentioned, please don't hesitate to use the chat or come off mute so that we can get that feedback. So recommendation number one is to repeal the current Minnesota state statute. It's section 260E.32, which says mandated testing does not meet the goals of providing patient-centered care. We also say this because Minnesota is only one of two states, the other is North Dakota, that has mandated toxicology testing for pregnant and birthing patients under certain circumstances. The third reason for that is because Minnesota is one of only four states, so Louisiana, North Dakota, and Wisconsin, that mandate toxicology testing of newborns in certain situations. Next slide. Recommendation two, to implement universal screenings using a self-administered or provider-administered validated verbal or written screening tool. The reason for this is because multiple screening tools are validated, recommended for using during pregnancy. Screenings should happen multiple times, and screening results should lead to a discussion with a provider. Next slide. Recommendation number three, conduct a toxicology testing only when it serves a medical treatment purpose. Reasons for this are some indications for newborn testing. If it affects the infant's clinical management, if a newborn's birthing parent meets criteria for toxicology testing and the results would alter their medical management, if key features or stigmata of fetal alcohol syndrome are present. And then indications for pregnant, birthing, or postpartum person testing would include concerns for oversedation or impairment in the postpartum period. That should prompt an immediate consult to the patient's medical provider for further assessment, and when the toxicology test would change the medical management of the pregnant person. Next slide. So before we move on, those are the first three draft recommendations. Are there any questions or concerns or additions or feedback of any kind that you all would like to lift up? I see Tiffany in the chat is applauding the state.
Yeah, and if you need us to back up a slide or two, if there's a particular one that you want to focus on, we can backwards up a bit.
Kurt, this is John Glover.
Yeah.
Yeah, Brittany, we've done quite a bit of work with alcohol screening and depression screening in our state, Wisconsin. And so one of the things that I encourage you to think about is the providers always ask us, once we get this screen and we have the results, what are we supposed to do with it? And do we have, referrals and places to support people? And I think that's a valid and important consideration. And I also think that if we do find a pregnant mother test positive in some way, how are we going to support her? How are we going to, take care of her? Because we know that this early stage of child development is so crucial, and supporting the mother is probably the most important thing we can do.
Absolutely. Thank you for that feedback, John.
Yeah,
I also see, I'm sorry, go ahead, Kurt.
Well, I was just going to say, John, and we're going to address some of that in the next four, actually. So we'll talk about that. One of the things that, and I don't mean to interrupt you, Brittany, but one of the things that was my big issue as we look at testing, and we were talking about some of these things, is a positive test for any substance only tells us that they've used once. And I think we always have to remember that, that it doesn't tell us pattern. So go ahead, Brittany, you were going to say?
No worries. I was just looking in the chat here. The first question, what toxicology screen do you use for alcohol? Was there one listed in our previous slide?
Currently, we do not. and as far as I know it. And as you all know, there's multiple ways for us to screen for alcohol. Doing PEth testing or breath. In my clinic, because we're hooked to treatment, we often have breathalyzers, but we can do urine or blood or other kinds of tests that will give us some hint as to whether or not there's been, for instance, alcohol used in the last few days, and potentially at what level. But again, one of the issues with testing as well that most of us understand is that even if we do confirmatories, what do those levels really mean, right? It can really change depending on the pattern of use and all of these things. So the screening test is something we haven't actually, that's not actually, in my mind, been really worked out, as has the screening tests that are verbal. Like if we look at the 5 Ps or we look at other things, which ones are we going to standardize for our state that are kind of the standard one? And I think some of that, in my opinion, again, you can weigh in as well, Brittany or Sam, is like we want to somewhat standardize it so we have the same results.
Mm-hmm. Yeah, a big conversation that was had on the task force was mitigating bias. And so making sure that there are standards that allow for consistency, especially because as we currently see, there's disproportionate representation for Indigenous and Black mothers. And so the standardization could also help with that. I see more questions in the chat. Where are the procedures drafts that we're commenting on? Have they received a copy of these slides?
Not yet, but they can after.
Okay. So we'll make sure we'll send them out. For now, they're just up on the slides that we're presenting. Is it best to have the patient use the screening tool and or providers asking the screening questions?
Yeah. In my clinic, of course, everybody I'm seeing there is there because there's an addiction issue. So my clinic is actually a little bit different where I'm not doing screening, but I have students almost all of the time. And the conversation I have with students is always the same, is that in my mind, having a very thoughtful conversation with the patient is probably better than most of the screens if they trust you and you're not judgmental. And you're really thoughtful in how you ask the questions. Some of the things with pregnancy, of course, with the 5 Ps, and some of the other things have been looked at. And so this is not something that we have, in my mind, solidified yet. As we go through some of the other stuff, you'll see kind of where we're at. But I really would appreciate anybody's thoughts on this. Brittany or Sam, I don't know if you have other thoughts on this particular thing.
Kurt, this is John. I agree with you that a thoughtful conversation is super important. One of the things, again, from our screening efforts previously has been that there is research showing that when the patient fills out the screener themselves without anyone, providing it to them, that we get better results. We get more clear and honest results. And I can tell you from working with folks, people oddly read a sentence differently, even though it's the same sentence on the paper. It's really interesting to hear how people read it. And sometimes it's just the inflection in your voice when you read the sentence, right? So I kind of default to wanting something written that the patient can fill out, followed by your thoughtful conversation, because that's so important to let them know how that information is going to be used, right? Instead of just whatever the screener is. And I can also say that we've found that brief screeners for that initial piece are the best. So that may further validate you, Kurt, that, a really short 2 or 3 questions, maybe 1 question if possible, followed by the thoughtful conversation really is the important.
Yeah, the way I actually lead into all of these conversations is I say, listen, I just want you to understand I'm not the police. My job here isn't to catch you at anything. My job is to get you a good outcome. And so I think it's important for patients, and I've had patients repeat that back to me the next visit, say, now I remember you saying you're not the police. So I'm going to tell you this, and I do think that's helpful.
I see some More
Go ahead.
questions here in the chat. Do these guidelines include recommendations for urine drug screens for the monthly visits, or is it just at the time of delivery for mothers? And I believe we've been recommending even for monthly visits if those are happening. Is that correct, Kurt?
Yeah, and it's really, and again, this is the thing. One of the things we're going to talk about in a moment is universal screening, so that we're either going to do it for everyone, or we're going to do it only in particular situations where there's child safety issues. Is kind of what I'm understanding that everybody on the task force has kind of leaned towards. So, and in a way, again, that's how we're trying to avoid picking and choosing who you're doing it to, because from the patients in my clinic, if they walked into an OB clinic, I think they'd be singled out frequently, right? And that's not the way we want this. It's either universal or it's based on specific findings or safety concerns. And we're going to talk about that as we look at some of these other reporting guidelines.
Mm-hmm.
Kurt, I wonder if that's where a brief initial screener might sort of help you identify who you might want to have a further conversation with.
Man, John, I'm glad you're here. You're helpful.
Yes, I. How are we doing on time? Do we need to go to the next set of recommendations?
How many more questions do we have there? Is there? It says talking to family members about a patient's use of substance and getting collateral information can be helpful to determine patterns or non-patterns of use. Yes, and I would agree with that.
Mm-hmm.
Sam, there's one about, would it be possible to put up a slide with the guidelines? And again, we can send these guidelines to people afterwards, correct? So Katie can send them out to everyone.
Yeah, and I tried to flip back to slide 3, which had some more, or recommendation 3, which had some more of those guidelines as we were discussing. So hopefully that met your needs. Otherwise, the full slide deck will be available to you after. We're not sharing the full report unless you want to send us a note or an email and we can put some contact information in. We're happy to share the full report. We also acknowledge that the draft protocol report is 20 pages and most people don't want to read the full report. So we have given it to you in slide format today.
All right, we probably better move on.
Yeah.
All right, so this is recommendation 4 of 10. And much like what Brittany talked about earlier, there is also considering the deletion of current Minnesota State Statute 260E.03 subdivision 15.5 and repeal section 260E.31. And basically what these are going to do is these are going to eliminate the laws. And again, currently this is not the way it is. So just understand, this would eliminate the laws that require reporting to Child Protection Services for substance use alone, or that classify substances used by pregnant or birthing individuals as child abuse or neglect. And I think that's really the important part, that it should not be considered child abuse or neglect. And part of that for me is that there's not intent, right? There's no intent by a pregnant person to harm their baby. They are using substances, they have a disease, they are not beating their child, they are not putting them in a closet. They are using substances. So instead, the new law will be created where reporting is based on the safety concerns for the infant. Is that baby safe in that environment? And that will be really the crux of it. It looks like there was a note. Will there be clarification on what is defined as a safety concern for the infant? Sam?
Well, in the full report, we have a table that notes the elements of safety concerns, and that was created with help from our task force members whose work in this environment. So they're part of child protection on the state level and have provided better guidance for when it is a concern for infant safety.
Okay. Anything else? So recommendation 5 is to create a notification system that actually meets the requirements of the child abuse Prevention and Treatment Act, which is referred to as CAPTA. Now, this would develop kind of a more nuanced pathway, and in a way, this is a bit how Connecticut is doing it. One of the people that we actually spoke with about how they're managing this second pathway. So you just think of this as you've got a pathway going towards child protection, and now we have a pathway that goes to support families with substance misuse and substance use disorders, which is separate from the Minnesota state system for reporting, again, alleged abuse and neglect, because we want to separate substance use from those terms. Notifications are intended for monitoring, for federal compliance as a part of that, the CAPTA, and also the public health planning to create a system of support. Some of this, understand that some of these things have not been developed yet. So I think it's important that this pathway is not developed yet, but this is the recommendation. And to give this support and care connection for those with substance use disorders. I didn't see if there's anything in the chat, Brittany, is there?
Yes, there were two comments in the chat. One was about a clinic where they did a initial screening at the patient's first visit. And then if that one was positive, then there would be ongoing testing. And then after the baby was born, then the baby and the placenta would be tested. And the person said THC was the only substance that they didn't have to report on, but that the OB providers did anyway. And then there was another comment or a question about wouldn't use during pregnancy be a safety concern when you consider the potential implications on the developing fetus and the complications that this may contribute as the child ages. And to answer, Kurt, I don't know if you want to respond as well, but to answer your question, Sarah, this is something that we've discussed a lot on the task force. And really what I believe that where we landed is we're trying to make sure that the statute itself is not doing harm to families. And I don't know that there is substantive evidence that not screening necessarily stops the use. This is more about how do we incentivize people to come to the table and to seek prenatal care, even if they are using. I think there's a difference between someone who's willing to receive and accept help and someone who has who is unable to. That would be how I see it, and also recognizing that this is people who are using during pregnancy are ill, right? We just like we think about mental illness or other illnesses, having compassion for the fact that addiction is real, right? And so sometimes it's not just the access barrier or the willingness, but if the person is at a place where they're able to receive help, and so I believe that's kind of where we landed is not being punishing the pregnant person who's struggling with an illness.
You know, and I 100% agree with everything she said. I think from a clinical standpoint in my clinic, I can have zero conversations about substance use if a patient's not coming in, and if they're not getting it. So in my world, and I say this all the time in my clinic, it's about progress. It's not about perfection. And the more conversations any of us can have with this patient group, the better chance we have at minimizing the problems that may occur and having better outcomes. So if they don't get prenatal care, no one talks to them, and they don't get the supports and all the other things they need as well. So yeah, beautifully answered, Brittany. Questions or comments on that? Anybody?
We had another comment that said it can be difficult to tie cognitive outcomes in a child or parent's actions or the exposure that happened in pregnancy. And so just kind of co-signing some of the rationale there and detangling substance use disorder from the legal system and addressing it as a healthcare issue. agreeing with recommendation 4 or 5, there's a real concern that mandatory testing of pregnant people and or request for self-reporting screeners may lead to them avoiding prenatal care, especially among populations that are over-surveilled by many other systems and who experience inequitable foster care regulations and enforcement. I'd also add inequitable connections to the justice system overall.
Yeah, and there was the comment about the Suboxone, and interestingly, and I have pregnant ladies all the time who are on Suboxone, and again, I always look at that as just another touch point to have the conversations about the other substances they may be using. Sadly, marijuana probably being the most common that they often continue to use, because in my mind, marijuana continues to be a real long-term issue for infants and children. So again, the more contact we have, I think the better the outcomes will be. So this is, we're going to 6. So that we're going to create a new law, and it's actually going to outline that outlines the notification is not a report of child abuse or neglect. So there's going to be some key changes in this language. And the notification of the Department of Children, Youth, and Families will be this online portal in which they'll fill out this form that meet the requirements of the Child Abuse Prevention and Treatment Act. Again, this notification will not be a report of child abuse or neglect. And so it may not, if there's not safety concerns, it may not be going to child protection. So it's a different pathway. Nothing shall prevent the healthcare professional or other persons from making a report. So we can't tell you to make a report or not. You obviously got to decide that yourself. But there will be a pathway that will be less punitive for this particular patient group. And so if you need to, you can make a report of alleged child abuse or neglect to local welfare if factors other than substance use by the birthing individual are present that impact health or safety of the newborn infant. So again, think of this as a split in the road. We can go child protection, or we can go to a different pathway where it's more about support and maintaining contact with that patient.
And I'll add in that this system isn't something we dreamed up in Minnesota. It's a system that's being used and has been used for a number of years in the state of Connecticut. And I believe something similar exists in Colorado. So it's been tested and used in other places and has proven to be a good pathway to get support, and then also when there are concerns for infant safety, that it's part of a protocol that allows us to keep kids safe as well.
Okay. Being no further questions, I guess. Oh, I think trying to end the stigma for pregnant women with SUD can be hard, especially some providers who tie their faith in with their profession. Yes, I would agree. All right. Anything else with those before we move on to the next? John, anything in comparison to Wisconsin that you see might be added or subtracted?
I just wish Wisconsin would do some of this.
All right.
I think I guess what I was thinking, Kurt, was I don't know about you. There must be the odd exception, but I think if we educate mothers on this situation, I don't know of a mother who would want to have her child experience the negative outcomes of substance use. I just think we need to educate people so that they understand why we're talking to them about it and the implications that it might have for their child. And I think that's a powerful way to affect change.
Yeah, and I think it's that and assuring access, right?
Yeah, right.
So, all right, next slide, I guess. All right, recommendation 7 of 10. So, excuse me, this will create kind of a uniform and a patient-centered process to notify local child welfare during pregnancy. So providers will recognize health and safety concerns early. And again, we want early intervention to prevent these future problems. Providers should consider and again, it's either universal screening, or there has to be some other way of having certain things that trigger it, unrelated to social situations or color or whatever. Provider and patient have a conversation to discuss concerns and unexpected results. And I think a big part of this is making plans or sitting down with the patients, like, how are we going to move forward in this particular situation? It is just helpful and suggested that there's an interdisciplinary team that check-in, which occurs with the patient, and that can include physicians, nurse practitioners, social workers, all people involved in this patient's care. Providers can consult with patient and community-based professionals. Again, that same group of social workers, public health, addiction services, if you have it in your community, to help secure services and supports for these patients. Again, pulling them in, not pushing them away. Providers, patients, and community-based professionals should initiate a plan of safe care. So at what point, if there is concerns about the child's safety, that there's a certain pathway that it goes. And lastly, providers would submit a blind notification to a Child Abuse Prevention and Treatment Act, again, CAPTA, notification portal, which is separate from Child Protection Portal. So these are the kind of the uniform and patient-centered process that is being pushed out. Thoughts on that, anyone?
I see a question in the chat about if the changes in language will make changes for those who are mandated reporters.
Now, my understanding would be that if the statutes change, that would change what you are mandated to report to whom. Okay. Again, if it's not child abuse or child neglect, you are not mandated to report it to child protection. But my understanding would be you would be mandated to put it in the portal, but that is de-identified. And again,
And I would say this is something that the task force that, we were told to report on testing and reporting protocols, but all the task force members, as we've come together, have said the laws and the system is broken. So our recommendations have been expanded because legal changes need to happen to break down some of those pathways like mandated reporting. So I really want to applaud this group as a facilitator because they've said, no, we have to change the bigger system and not just narrowly look at testing and reporting, which I think is just a really holistic way of addressing these issues.
I think there's probably a lot of providers on this call that have lost sleep over trying to decide whether you needed to report something or not, and how it was going to affect somebody's life and their children, and them not seeing their baby in the nursery and then it disappears into foster care. I mean, these are things that providers have had to deal with for 30 years of my career, and they're tough decisions, and it changes people's lives. And I think in a way it just continues the cycle that we already have. So hopefully this will improve that.
I see another question in the chat asking if it would be mandated to report to CAPTA or the discretion of the provider.
Samantha, I don't know. Brittany, I don't know if we've talked about that specifically.
I know that step 7 on this is meant from our DHS child protection colleagues on the task force, that the notification will allow you to be in compliance with CAPTA. So the notification would happen. So we don't want to change every system because that's unrealistic, but it would meet your reporting. It wouldn't be reporting in the way that you're reporting currently because it's now a blind notification.
All right, we better keep moving. And my last slide, we need to create a uniform process for reporting to the Department of Children, Youth, and Families and local child welfare after birth. Similar protocol to previous notification plan, but concerns about child safety lead to a report to child welfare. Again, child safety. So can this person care for this child, and is the child safe? No concerns for child safety follow steps of creating a plan of safe care and exploring supports. Strengths and safety challenges should be used to determine reports to child welfare. So again, trying to separate the two, safe baby or not safe baby. And any other questions before we move to Brittany's last couple? We've got 15 minutes, so will pregnant persons have the agency to refuse to be screened during prenatal care through testing? Through a test or self-report, will they at least be notified if their test is being done? That's a loaded question.
So I will say we have talked a lot about consent on the task force and making sure that a pregnant person is aware if testing does happen. Now, if they refuse the screening, I'm not sure where we landed with that part.
From what I understand from medical providers, some of that comes down to the institution, but our recommendation was you would have to have consent unless it was medically necessary and you were unable to consent, right? Which sounds like it's similar to current medical protocol.
Yeah,
So our goal would be is that they would have to agree to it.
Yeah, well, my understanding too is that if the baby was having complications, then the testing could be done on the baby or placenta if there's some big issue, which is a roundabout way. Mm-hmm.
I will say that some of in our input process, we are going to have some legal teams at major medical institutions take a look at this to notice where there might be some hangups that we all as members without legal expertise can give some better insights into it. So thanks for bringing that up, and we're checking it out as well.
Next slide.
Kurt, this is John. We did look at some of that. That's where universal screening can be helpful. We screen everybody. You're not different from anyone else. Although we also found that was helpful to have signage up to let people know that this was not directed at them, that this was something that everybody was asked to do. But at no time did we require people to do a screen. If they preferred not to do a screen, then of course it went to your thoughtful conversation with the provider, right? Mm-hmm.
All right, last two recommendations. Number 9, improve access to systems and supports, including prenatal care for pregnant people and their families. So we want systems and supports to include family-centered treatment, housing, childcare, transportation, education, employment, and other social determinants of health, especially in remote and rural areas. We want to ensure that there is continued access to prenatal care and that we harness the expertise of existing groups within the state of Minnesota, working to develop and implement policies and strategies to improve systems and supports for Minnesotans experiencing substance use disorder. Next slide. Recommendation number 10 is to create a sustainable model for both the implementation of task force recommendations and the development of future best practice guidelines. So we want to address funding sustainability and to create a multidisciplinary team to create those best practice guidelines. So that is recommendation number 9 and 10. Were there any specific questions about those two or overall anything that people wanted to revisit before we wrap?
It says, has the task force considered recommending funding for doulas or other supports? Brittany, maybe you.
So I'm here today in my children's cabinet hat, but I'm also a doula. So we have talked about the perspectives of doulas and other community supports. We haven't specifically talked about funding, but as you may or may not know, there are some additional investments for doulas that came out of the more recent legislative sessions. And I think it's definitely something when we think about, I want to say recommendation 8. One of the recommendations when it talks about connecting the birthing parent to community supports and thinking about the social determinants of health, I think anyone who is a practitioner or who can provide a level of service and support for our birthing parents, we want to make sure that they have what they need to be successful for sure. And some of that did include workforce support.
Now, people should understand as well as that these present 10 recommendations, we've actually done some wordsmithing on it, and there's going to be lots more of that kind of done. Any thoughts that any of you may have as you look through these that you may think need to be considered, please feel free to send those. We are not the smartest people in the world, and we spent a lot of time on this, and you might have a much better idea in a millisecond. So please feel free to send us some feedback on these. It's still a long road because these have to be handed in December. So there's a lot of stuff that's going to need to be kind of worked out as it hits the legislature. Where it goes from there, I have no idea. Maybe Sam knows that.
I unfortunately don't know that, but we're trying to get a better pathway. We know, again, we have members on our task force that are deeply ingrained in systems that want to make sure that we change the notification system, for instance, in child protection. So they're already including some of this information into some of their future team plans. And the hope is that the legislature will take a look at this and make some changes and recommendations and hopefully changes to laws. That's what we're hoping to be able to advocate for.
Yeah.
But like Kurt said, I put in the meeting chat the link to a Qualtrics form. If you have focused feedback that you weren't comfortable sharing in the chat, we would love for you to share it through that link. Otherwise, if you've shared it in the chat, we're going to put that into our notes and put it as part of our feedback from this session. So don't feel like you have to tell us what you already told us during the presentation.
Yeah, I think in a perfect world, as this kind of moves through things, for those of you who care for this patient group, it will hopefully clarify a lot of the things that we've struggled with for decades as we try and keep families together, especially families with substance use disorders in the family, and not break them apart and put people in foster homes and all kinds of stuff that's gone on so far. So, and this whole, for me, has always been, who do I report and how do I feel about it? And I think if I have a pathway that's supportive and is going to help this patient group, I think we can all be hopefully pretty excited about that. Anything else, Brittany or Sam, before we let everybody go? All right, everyone, we thank you so much for your attention. And again, we would love any kind of feedback you give. We'll be back here in 2 weeks with Suboxone rounds with some fun cases, and everybody can kind of learn about how a few different addiction people start their patients on Suboxone in lots of different scenarios. So it's going to be a fun and interactive one. So thanks again for coming. We'll see you guys all in a couple of weeks. Thanks, Brittany. Thanks, Sam.